Taking over from this point ahead, I shall be discussing options for placing an IOL when there is no capsular support. So we have had a good phaco surgery, everything has gone smoothly, and IOL is placed in the bag. Excellent. But sometimes this is not always possible. But we still have a lot of options. The age-old option of aphakic glasses may not be suitable anymore. We have three-piece IOLs, anterior chamber intraocular lenses, iris fixated lenses, and various ways in which these can be used. The IOLs can be placed in the sulcus. Anterior chamber IOLs can be used. IOLs can be fixated to the iris, one method of which we already saw, or they can be scleral fixated. This is a video showing how an IOL can be placed in a sulcus. This is a secondary sulcus fixation. Patient has already had a cataract surgery following trauma, and there is a good rim of capsule remaining in the sulcus. So after a section is made, visco is injected to form the anterior chamber, and all the adhesions between the iris and the capsule are separated to ensure that there is good capsular support, and a three-piece IOL is placed in the sulcus and is carefully dialed into place, taking care to place the haptics in the area where the rim is well intact. The sulcus fixation of an IOL can also be done in a primary setting, which is what is recommended when you do not have an intact posterior capsule. Anterior chamber IOLs, though were popular in the past, are soon falling out of favor due to numerous complications like corneal decompensation and secondary glaucoma. Iris fixation can be iris sutured or iris claw. Iris claw was initially devised by Jan Wurst in 1978, and they used to be anteriorly fixated, but this carried a risk of corneal endothelial damage. Retropupillary iris claw is an easy technique and is quick to perform and will be soon demonstrated by Dr. Nivian. It needs an intact iris and it's fast gaining a lot of popularity. So iris suture, as we saw, is a little tricky technique, and there is a risk of dislocation due to erosion of the proline. And in any form of iris fixation, there is a risk of iris atrophy, pigment dispersion, pupillary irregularity, or poorer dilatation. Though if the lens is fixated in a proper position on the iris, these problems can be overcome. Scleral fixation, there are numerous procedures and numerous modifications of these procedures, the two main of them being the sutured or the sutureless. The sutured can be either with the Prolene with a 2 or a 4-point fixation, or with a Gore-Tex suture, or a sutureless can be glued or without glue. Sutured SFILs are the time-tested technique, have been around for a long time, and though they are found to be better in certain circumstances, like when there is a large pupil limbus to limbus diameter, because in such cases exteriorizing and tucking the haptics often fall short and have a risk of dislocating into the eyes. Also sometimes when they are post-trauma eyes, or when a primary cataract wound was very badly extended or constructed and there's very poor globe stability, even in those cases the sutureless can be difficult, or when there's extensive scarring of the sclera or conjunctiva. These places sutured definitely has an edge over the sutureless technique. They are a bit cumbersome to perform, and we need to be careful not to entangle the sutures, and it is reported that these IOLs may drop over time after 10 to 15 years, mainly due to suture erosion. So this is a video. Now this video demonstrates 4-point sutured scleral fixation and also removal of a dropped IOL. So initially, after marking the 2 horizontal meridians, I proceed to make these scleral flaps. I use triangular, they can also be quadrangular in shape, or the Hoffman pockets. A superior section is constructed and kept in place. 3-port vitrectomy is done. There's a single piece dropped IOL in the vitreous cavity. Ensuring a total vitrectomy, a small bubble of PFCL is placed on the posterior pole just to help picking up the nucleus, the IOL, and the IOL is positioned over the PFCL, because I am not very fond of picking it up directly from the surface of the retina. Now with an end grasping or an IOL holding forceps, either one, whichever the surgeon prefers, the lens is picked up from the posterior pole and brought anteriorly. The incision is entered with the keratome in the left hand, and the IOL is exteriorized from the eye. Following this, the PFCL bubble is removed from the eye, and now I proceed to do the sutured SFIL. 1.5 mm from the limbus. 2 straight-armed 9-0 or 10-0 Prolene sutures are threaded over a cannula and exteriorized from the main wound, passed through the eyelets in the haptics of this specialized IOL for sutured SFIL, and again brought back by docking into a 26 gauge needle. Should be sure when you pass the sutures into the eyelets, one should go from above down and the other from down up to prevent torsion. IOL is introduced into the eye and the sutures are slowly pulled on both the sides to achieve a good centration and are tied on the two sides with multiple throws of the suture. Sutureless is fast becoming a more popular technique introduced initially by Gabor and has multiple modifications like the use of glue to fixate the haptic and a flap, the flange technique or the Emanet technique, and the X-knit technique, which the X-knit will also be soon demonstrated to you by Dr. Prabhu. It needs specialized forceps and is best done with a 3-piece IOL. It is very good as you can refixate a dropped, posteriorly dislocated or a dropped 3-piece IOL, and can also use acrylic and multifocal IOLs. It's difficult to perform if the globe is not well formed, and if the haptic needs to be fixated in very odd angles, especially in patients post-trauma, it can sometimes be difficult. So this is a sutureless acrylic IOL being done here. Again, after marking the 2 horizontal meridians, I proceed to make these small nicks in the conjunctiva, and these are the tangential scleral pockets being made where 23 gauge MBR blade, where the haptic will be fixated, proceeding with a total vitrectomy. Now these entries are made into the eye with the 24 gauge needle just at the beginning of the 2 tangential pockets, and a clear corneal incision is performed. The curved forceps, I use the Dork IOL holding forceps, which come as a pair, a curved and a straight. And here the IOL, a 3-piece sensor IOL is being injected into the eye, and the leading haptic is grasped by the forceps. And the IOL is slowly unfolded into the eye, and the trailing haptic is left out of the main incision. And the proceed to tuck the leading haptic with the straight of the forceps pair. Now proceeding to get out the second haptic, and now this is tucked into position into the preformed tunnels, and so this can be a completely sutureless technique of fixing a IOL in the eye. Now here this is a refixating a 3-piece IOL which is grossly subluxated over here. Again the same thing, 2 horizontal incisions made and the 2 tunnels being performed on 0.5 mm from the limbus for tucking the haptics. Proceed with the vitrectomy and try to completely dislocate the subluxated IOL into the eye, which can sometimes be quite tricky. Proceed with the base dissection, especially at least in the areas where I fixate the haptic I prefer. Again, a small bubble of PFCL on the posterior pole just to stabilize the IOL on it. I rechecking the entry of the 2 tunnels and making the entries with the 24 gauge needle. Now with the straight forceps of the pair and an endoilluminator in one hand, go into the eye and pick up the haptic, bring it out of the eyeball and tuck it into place. And now the same thing will be repeated for the other haptic. Sometimes when one haptic is placed in the eyeball, the other haptic becomes quite anterior, and we can just pick it up even without the visualization system, and it goes into place. So this technique is very good here. If you already have a 3-piece IOL in the eye, the same IOL can be refixated without any necessity to remove it out of the eyeball. There are multiple options as we have discussed over here, and which is best is the one which the surgeon is the most comfortable and proficient in performing. Thank you.